Hello, my today's presentation is on imaging of bronchiectasis. Bronchiectasis is defined as irreversible dilatation of a portion of the bronchial tree. The three most important mechanisms that contribute to the pathogenesis of bronchiectasis are infection, airway obstruction, and peribronchial fibrosis. On imaging, we assess bronchoarterial ratio, where we compare caliber of the bronchus and adjacent branch of the pulmonary artery. If the bronchus is significantly dilated, we can see a signet ring sign. There are different types of bronchiectasis, including cylindrical, varicose, and cystic. You can also hear a term traction bronchiectasis that doesn't represent bronchial dilatation related to inflammation but to fibrosis. Chest X-ray in patients with bronchiectasis is often normal or non-specific, and diagnosis and assessment of bronchiectasis is done on CT. However, the chest X-ray does have a role in surveillance for intercurrent infections or progressive lobar collapse or suspected development of cavitary disease. It can also give you an idea of the distribution of the disease. On chest X-rays, we can see bronchiectasis either directly as tram-track lines, tubular opacities, or ring opacities. There are also indirect signs, particularly in advanced disease, such as lobar atelectasis, that is secondary to mucus plugging, or compensatory overinflation of the less affected lobe or the whole lung. In patients with advanced disease, we can frequently see directly the dilated bronchi. On the X-ray on the left, you can clearly see dilated bronchi in the lingula and the left lower lobe associated with multiple air fluid levels suggestive of active infection. The second X-ray shows tubular branching opacities in the right upper lobe that have appearances of fingers in a glove. This represents mucus impaction in dilated bronchi and is typical for patients with allergic bronchopulmonary aspergillosis. There are diseases with bronchiectasis that have typical appearances on chest X-rays. On the left, you can see upper lobar predominant bronchiectasis associated with fibrosis. This is typical for cystic fibrosis. On the right, there is dextrocardia and bronchiectasis with lower predominance. This is a typical finding in patients with Carter-Goddard syndrome. Direct signs of bronchiectasis represent bronchial dilatation when bronchial lumen is much larger than the caliber of the adjacent branch of the pulmonary artery. This is called signet ring sign. The arrow shows a very good example. We can also see abnormality of the contour of the airway. Typically, we see absence of tapering more than 2 centimeters beyond bifurcation, and if you see airway visible less than 1 centimeter of costal pleura, this is bronchiectasis as seen at the bottom image. Morphologically, there are 3 types of bronchiectasis. The commonest bronchiectasis is cylindrical, as seen in the image on the in the left upper corner. Then we can see varicose bronchiectasis as shown in the right upper corner, and in the middle and the bottom images show examples of cystic bronchiectasis. Historically, HRCT of the lungs meant images only in axial plane. However, with development of multi-detector CT scanners, we have images in other planes such as sagittal and coronal planes, as seen on this slide. The multiplanar reconstructions allow us to assess better the anatomy of the lungs and extent of bronchiectasis. There's a very useful post-processing technique called minimum intensity projection, or MINIP, that allows better visualization of abnormal airways, but also helps to visualize abnormal areas of the lungs due to airway disease. And this is called mosaic attenuation, and on scans in expiratory phase, air trapping. Please see the darker areas of the lungs. Indirect signs of bronchiectasis on CT are bronchial wall thickening, mucoid impaction or retained fluid within bronchi, tree in bud nodules, mosaic attenuation or air trapping in expiration, and bronchial artery hypertrophy. This can be seen better on contrast scans. In CT reports, you can find terms such as mosaic attenuation and air trapping. These are descriptive terms for non-specific finding of patchwork of regions with different pulmonary attenuation, as seen in the images below. Mosaic attenuation is used for changes on scans in inspiratory phase. Air trapping is a term used for findings on scans in expiratory phase. These typically represent obstructive small airway disease and are frequently seen on scans of patients with bronchiectasis. In patients without airway abnormalities, these can represent occlusive pulmonary vascular disease. Another interesting radiological term is tree in bud nodules. These are multiple areas of centrilobular nodules with a linear branching pattern that have appearances of a budding tree and represent pathological content in bronchioles. In patients with advanced bronchiectasis, you can also see other findings such as lobar collapse or mycetoma formation or fungus ball, as seen in the image on the right. The fungus balls represent important cause of hemoptysis. Bronchiectasis could be localized, affecting only one single airway, as seen in the images here. There's an incidental finding of extensive pneumomediastinum that is not related to the bronchiectasis. Bronchiectasis can affect only one lung as a result of bronchial stenosis, occlusion, or post-viral bronchiolitis. Most often, the bronchiectasis affect both lungs in patients with recurrent infections. The bronchiectasis typically have lower lobar predominance in patients with cystic fibrosis. The bronchiectasis have typically upper lobar predominance. There are several diseases with bronchiectasis that have specific CT findings, such as allergic bronchopulmonary aspergillosis, Swyer-James syndrome, Carter-Genner syndrome, non-tuberculous mycobacterial infection, Meunier-Kuhn's disease, alpha-1 antitrypsin deficiency, and cystic fibrosis. Patients with allergic bronchopulmonary aspergillosis typically present with large central bronchiectasis that are filled with dense content, have appearances of fingers in gloves. Individuals with Carter-Genner syndrome present with dextrocardia, bronchiectasis with lower lobar predominance and extensive mucosa thickening in their paranasal sinuses. Non-tuberculous mycobacterial infection is typically seen in ladies in their 60s and 70s with background of bronchiectasis, and this is associated with multiple clusters of 3-in-bud nodules as seen in this image in the right middle and right lower lobes. Meunier-Kuhn disease is a very rare disease presenting with tracheobronchomegaly as seen in the images below. Diagnosis of bronchiectasis on imaging is not always as straightforward as it may seem. There are conditions that may mimic bronchiectasis in patients who are short of breath and cannot hold their breath. The motion artifacts can mimic bronchiectasis. Also in the lingula, the motion of the left ventricle can mimic bronchiectasis. Traction bronchiectasis is a specific term used to describe abnormal airways in patients with advanced pulmonary fibrosis and is not related to recurrent infections. The airways within consolidation can have abnormal appearances, but these shouldn't be called bronchiectasis as they frequently resolve after the resolution of the consolidation. Bronchiectasis also may mimic other conditions such as cystic bronchiectasis are frequently being reported as cysts or cavities, and mucus impaction bronchocele are being reported as pulmonary nodules. These are examples of significantly abnormal airways in the periphery of the lungs affected by advanced fibrosis. And this is a feature of pulmonary fibrosis and not related to recurrent inflammation. Before concluding my talk, I would like to make several comments on bronchial artery embolization for massive hemoptysis. The definition of massive hemoptysis is 500 or more milliliters of blood in a period of 24 hours, but interventional radiologists are flexible with this. Most of these patients have had all conservative options exhausted. Most referrals for chronic or acute on chronic hemoptysis are caused by bronchiectasis or tuberculosis. Bronchoscopy prior the procedure is helpful to establish the site of bleed and we can just concentrate on one lung as opposed to doing both. This reduces risk of complications, time and complexity of procedure. Normal bronchial arteries are too small and very difficult to visualize on imaging. In patients with chronic or acute on chronic bleeding, there's usually an element of bronchial artery hypertrophy. The hypertrophic arteries represent the target for embolization. For successful procedure, and access to the aorta is needed. In patients with occluded common femoral or iliac arteries, brachial artery access can be used, but this comes with higher risk, and this access is technically difficult. Images on this slide show examples of hypertrophic bronchial arteries on an angiogram. The abnormal arteries were identified on a CT scan. Prior to the procedure, patients with massive hemoptysis will need to have platelets and clotting corrected to near normal, which is INR less than 1.5 and platelets over 60,000 in microliter. This depends on the operator and urgency of the procedure. Cooperative patient who's able to hold their breath for a few seconds and lie flat and still for about an hour is essential for quality imaging and the ability to complete the procedure. They will need to lie flat for a few hours afterwards and have groin puncture site ops for 6 hours post the procedure. Here's another example of hypertrophy of bronchial arteries on CT and on angiogram. The images and comments were kindly provided by Dr. Will Adair, interventional radiologist here at UHL. All interventions come with a certain risk, and bronchial artery embolization is no different. Most interventional radiology procedures have small mortality, but usually much less than open procedures. We can see usual groin complications such as pseudoaneurysm, bleeding, and dissection in about 1% of the cases. Terrible complication of bronchial artery embolization is spinal cord ischemia that can be seen in up to 6.5% of the cases. The risk can be reduced by good quality imaging and favorable anatomy. Stroke and peripheral nerve injury are complications typically seen in patients with brachial artery access. Ruptured bronchial artery is an uncommon complication of the procedure. Obviously, there could be also failure of the procedure when the anatomy and origin of the bronchial arteries make cannulation challenging or even impossible. Thank you for your attention.